Dr. Jeremy Boyd, welcome back, man.
So thank you. Thank you for having me back here again, Altamash.
I love it, man. We're in the same uniform, right? You've got the hoodie you represented, and it certainly looks good on you. So I love that. So I want to pick right back up, right? So this is just going to be you and I. We're going to talk about something a bit more strategic, something more tactical. Last discussion that we had, we took a, dare I say, more philosophical approach at rehab, looking at that whole person, holistic, as cliche as those words are, and just understanding, treating between the years, how important that is. But what I want to talk about today with you is this concept that you introduced me to, something that is, I don't think, something that I would even have thought of or ever heard about during my training. You have some rumblings peripherally about these concepts, but, it's just, you have certain things that you learn in the sports medicine realm, and that's the way it is. That's the way it's always been done. That's the way it's going to continue to be done. And that's the only way that is, and that seems to work the best. And you always think that, okay, well, there's no dispute. This is the best way. And, with all that suspense build up, I think I'll tell the listeners now, it's this concept of treating ACL injuries, which is a highly prevalent injury, particularly in athletics, treating it non-operatively, right? For the longest time, people have learned that if you have functional goals and goals at performing at a high level, well, you need to have your ACL reconstructed. You, my friend, are here to probably challenge that today, and hopefully we can have some good discussion. So with the state stat there, I also want to actually know, I don't think I've ever learned this about you. I might have mentioned this to you when I went up to that course for the hip course. I met somebody there who had seen me wearing the trifecta shirt and said, oh yeah, Jeremy, like he's the ACL guy. So I don't know you as that, but supposedly some people in the rehab community know you as the ACL guy. So tell us a little bit about what even stemmed your interest in that particular injury and just your background in that.
Yeah, so I'm going to give all the flowers to my mentor, Dr. Sharon Wentworth. She's probably the real ACL PT. So my final affiliation at PT school, I got lucky and blessed to be with her. That's where I got a lot of my sports rehab experience, or all of it at that time. And she built this awesome model, like a true sports rehabilitation model, piggybacked with strength and conditioning and performance, where I think she would say it like, oh, it's like half and half, but really like 80-90% of her clientele were ACL injuries, like post-ops and everything like that. So they would see all the other types of sports injuries, but it was like ACL after ACL after ACL, still to this case. And, they do great up there. And she definitely exposed me to it. I started getting the interest in it when I was probably my first affiliation. I did my in-service on ACL tears. So I did this before I even knew Sharon. So this is when I was with Dr. Terry Andrews. I think probably at the time, maybe it was Donovan McNabb and Tom Brady went through ACL injuries. And I thought it was pretty incredible, their comebacks at the time. I remember when I was playing high school soccer, one of my teammates accidentally tore his ACL, and it was still kind of back there. So I graduated 2007, where it was like, oh, could kind of end your career. And he came back, was like all state. He was great. Like he went through a whole, year-long rehabilitation, and he came back, better than me. He was better than me when he got injured, but I had a whole year to not like focus on rehab, and he's still much better than me. So I think that's like when I like really look back at it. That's really what started it. Then I had it in service, and then I got with Sharon Wentworth. And then, I wanted to, what people are attracted to me and why they may call me the ACL guy was, I guess mostly, obviously ACL is mostly a sports injury, obviously. And most of those individuals go to your classic sports rehabilitation. And I got so much knowledge, a different style when I was with Terry, and that was a more traditional orthopedic manual physical therapy clinic. He had his COMT, which is a certified orthopedic therapist. He had his orthopedic clinical specialty. And then there was the sports side, which is a little more faster pace, a lot more into loading and everything like that. Not as much into the manual therapy and as much as Terry's, but I saw the benefits of both. And, so it's like, I think those worlds should be more blended together. But a lot of people say ACLs are, it's you have to get the knee moving and the fully straight and bending, the full flexion, such and so forth, get quiet knee and move them along into the strength and conditioning phase. And I think all the, post-ops are kind of labeled a simple sort of thing. But once you start to see a lot of these ACL injuries or post-op ACLs, you start to see that everyone's incredibly unique. Whether what you have to do from a manual perspective, like what technique or mobilization, whether it's neuromobilization or scar tissue or joint based, or, what education or what kind of psychology work you have to do to them, what muscles that particular athlete needs to maybe more focus on. Obviously, making them more resilient is the key for everything, but, go into nuances of everybody's like unique sport. So I saw that, should be blended together. And that's, created some courses and done a lot of research on that, trying to blend all the realms of like orthopedic, manual physical therapy, traditional sports rehab, sports psychology into the mix, and, started treating a lot of ACL plates. So we've had really great outcomes, and I fully believe it's due to that whole type of approach. I guess, the ACL again. I like treating a lot of things, but ACL is what I'm most known for.
So I think maybe it's worth taking a step back, because I'm taking this for granted that everybody really knows what an ACL is. People might have heard about ACL injuries, but maybe we could define the structure a little bit, the anatomy, just to give people a lay of the land of what that area looks like. And if you want or think it's necessary to talk about the vascularity and that kind of stuff, feel free.
Yeah, I think it's important to know the anatomy, and then even also even beyond the vascular, which we'll talk about if we want to get down into the self-regeneration component of potential ACL injuries, but also the nerve input as well, which I think is incredibly missed with a lot of our, post-op situations. The ACL, as we know, is in the knee, and goes, I don't typically have a model in the clinic, but the main function of it just prevents that. So two components, obviously the anterior shear of the tibia on the femur, and also provides some rotation stability as well. So it runs from, in the horizontal kind of sort of way from your tibia to the anterior to the posterior medial aspect of the femur. So going from lateral to medial. So that's the, kind of the anatomy of it. It's innervated by the tibial nerve, which I think is important. It's a highly neurovascularized tissue, which I think is, again, missed out a lot, especially in the post-op sort of situation. We talk about it from, there's a lot of loss of proprioception or somatic sensation, a lot of ability to kind of know where the joint is in space, if that makes any sense. And that's due to a lot of obviously the neural input from that ligament. So it provides a lot of information to the brain, that's why it's so important to one of two things. We're suggesting that it can potentially regenerate, or we, reconstruct it, but that's also going to be met. You're not going to fully be able to restore the properties of that. But, so that's the main kind of anatomy overview. There's a lot of stuff that happens and, what it does in support, again, just from a sports or stability component, again, mostly from, preventing that kind of shear or rotary forces. It works in conjunction with other ligaments, your hamstrings working synergistically to prevent that kind of anterior shear. But yeah, it's arguably the biggest static stabilizer of the knee. So compare like dynamic versus static. Static is more your ligaments, the joint itself, the bones, versus, a dynamic stabilizer, let's say like the hamstrings, which, they have to be contracting to provide that stability component. The ACL always provides it. So that's just the overview of it.
I think just to kind of, for those who are listening and not watching here, just so they have an understanding that the shear forces you're talking about, another way to explain that would be translation, right? So we talk about the tibia, which is your shin bone, translating anteriorly, so moving forward on your femur, which is your thigh bone, right? Or the exact opposite. You have posterior translation or backwards of the femur on the tibia. And that's kind of the shearing that you're talking about. And oftentimes, if you've ever experienced that type of injury and a clinician has examined you, you probably have experienced them trying to recreate that motion to see if there is looseness or laxity, as we call it, in that. And so, like, to your point, yeah, I tell patients, I'll use the terms active stabilizers and passive stabilizers. Maybe it's not the best term, but it's just trying to demonstrate the idea that, for tendons as being your active stabilizers is something that you can more robustly train up. Although I'm sure we can make the argument that ligaments can be strengthened as well with rehab.
Yeah.
So
there's actually research to support that. I think they did a study on soccer players after the length of the season and strength training that the ligament does become more thickened, which typically is mostly what we want. Again, there can be argument of like a hypertrophic or overly thickened ligament may be problematic, but I've never really heard that's the case. It's more of an issue like in tendons. But it does respond to stress in a generally positive way, or like physical stressors, like when we do training and everything like that, but not as much or as impactful, obviously, as a muscle from the tendons from a dynamic standpoint.
Awesome. So let's get into it, right? So we talked about a little bit of the anatomy, the function, and I think it's also worth noting, I mentioned the high prevalence of it. I think some of the recent data is, up to 200,000 ACL injuries occur annually in the United States. And I'm sure when you take the worldwide, and especially in sports such as soccer all over the world, that probably is going to be an exponential increase in that. ACL reconstructions, we have about 100,000. And this is one of the most common procedures in knee arthroscopy, probably after some type of meniscectomy procedure where they're shaving the meniscus out, but oftentimes they go hand in hand. But like any other intervention, and certainly any other surgical procedure, it is not without its risks. And so we'll talk about that. And I highlighted at the outset that the standard of care for a long time, and maybe still to this day, at the very least, the way that we're being trained, I'm a primary care sports medicine doc, so I always want to disclose my non-surgical bias. Despite that, it's almost dogma that when somebody who has aspirations of getting back to return to sport, you would be doing them a disservice if you did not get a surgical consultation or if they didn't get surgery. And so, with that, tell me a little bit about what the potential of ACLs healing on their own. What's the evidence, right? You talked about some regeneration capabilities, and are there studies that's looked at this that you're familiar with, and talk about that a little bit?
Yeah. So I'll backtrack a little bit now. So there's, in the classic sense, that is that, it used to be, I used to think Achilles tendon ruptures, ACL tears, those were like, you get them. Unfortunately, you suffer those injuries, you were getting surgery in the next couple of weeks it used to be immediately. Now we know establish, kind of some normal homeostasis, not a crazy inflamed, area. We're giving it a little bit of time before we go and operate on these particular areas, but still, nonetheless,
just tell people what homeostasis is.
It's balance within the system, I think, is the best way to describe homeostasis. Versus, when you have an acute injury, you're going to get an inflammatory response. You're going to get all your healing tissues and fluid edema. They swell the joint to, try and heal the tissues as quickly as possible, but that's not when we want to do an operation, because that's going to also cause an inflammatory response. So doubling down on that typically leads to worse outcomes. So that's why rehab was created for a lot of procedures, especially in ACLs, which there's a ton of evidence supporting that. It's arguably the most important stage. Talk about stages of ACL rehabilitation. That's arguably the most important stage, because that sets the tone and everything like that. So you want to get, you'll see a lot in the literature, in regards to ACLs, it's a quiet knee. So it's a knee that's not overly inflamed. Well, you may see like a centimeter of swelling in the knee compared to the other one, like a little bit, sure, that's okay. But the knee should be able to kind of function and form like a normal knee for the most part. Not much pain at all, or no pain, ideally, relatively full range of motion. So that's ideally what we want. So that's from a, pre-surgery kind of standpoint. But again, no matter what, it was thought that you had that, you're eventually going to get it. Whether back in the day, we're doing it, tomorrow, and now it's a little bit more delayed for most individuals, a couple of weeks to a month. Some people even longer than that, depending on how long it takes them to get to a quiet knee. But now we have reconstructions, which is that's the classic, that's a gold standard, I would say. We now have repairs where they're trying to so reconstructions when the ACL is torn, they go in and they remove the stumps or what was left of the ACL. They take the footprint of where that ACL was and they go and get a graft, which is typically for most individuals, I think still the gold standard. So a patellar tendon. So they take out the middle part of your patellar tendon. So imagine that as my middle finger and between my index and my ring finger for people that are listening in. Take that out.
Patellar and a bit more of a push for hamstring too now.
Hamstring. And now there's even another push for quadriceps.
Yeah, I saw that.
Still a debate. To me personally, I've worked with all three, had the same outcomes. They return to sport. They're fine. I think more struggles in the quadriceps world just because most people have an issue with their quadriceps returning for any of the ACL, even using a hamstring. So with a hamstring, they take some of your hamstring tendon, create a graft out of it, and your gracilis, which is more of an adductor muscle, and create a graft. So that'd be a reconstruction. Hamstrings are, they're popular when I came out of school, I think it's starting to level out again. They're starting to see, and there's some cool studies I could send you guys where they're starting to subgroup and identify based off of the athlete and the kind of the phenotype or the body type of the individual, or it's maybe we should push this type of graft on this individual now, which is great. So we have a larger individual, a quadriceps tendon tends to be a little bit better because it's a thicker type of tendon. So maybe start to push that. We have a sprinting individual. Maybe we don't want to take their hamstrings, since hamstrings are incredibly important. Sprinters, they classically pull their hamstrings anyway. So why would we try and weaken in the tissue that they already have issues with anyways? So we're starting to see that. So whether a graft there is, and then there's the allograft, which is a cadaver, getting it from obviously cadaver cell, which is, typically not reserved for as much of the active or the athlete, unless that individual has had multiple tears, or they do see it sometimes in pediatrics where they don't want to go out and get a graft, or there's something with the tissues. Those are all the reconstructions. We're now starting to see in last couple of years, repairs, where we're trying to essentially sew the ACL back together and using bioaugmentation to help heal it quicker. They did try this way back in the 1930s. We'll just kind of sew back together, but we didn't have the technology. I was living back then, ACL and the medical practitioners. So even before that, they tried, but again, they didn't have the tools to actually have the repair work. So it just retore. The re-tear rates were pretty bad. And that's what kind of fed into the reconstruction route. But now with all the advancements in, orthobiologics, improvement in our rehabilitation processes, being smarter about when we can, progress to A, B, C, D, E, and F, we now have repairs. So that's exciting. And then we have no non-operative, not do anything. I'm going to live without an ACL. And those are the copers. And you'll hear me say that a bunch of times. So those individuals are just saying, hey, I can function based off of, now there's certain parameters that we know by evidence that these individuals are going to be able to function without an ACL. And now we have a fourth group in the last couple of years, since 2022, 2023, where I started to see a lot of it, where they're actually bracing individuals to help self-regenerate the ACL, to actually see MRI changes where the ACL starts to regenerate and grows back on itself, which I think is super cool. I'll be the first one to admit I have not had a patient who's undergone that. I have yet to know of anybody in the States that has. This is more, I think, big push in Australia and Europe for trying those sort of things. So those are the four options. And if you tear your ACL, what kind of route you can go to.
Now, Jeremy, is this the cross bracing protocol you and I were talking about at 90 degrees?
Yeah. 90 plus degrees.
Yeah. I'll mention that later on. So it's just to kind of recap, right? So we got the ACL reconstruction, which has been the mainstay, right? And so that could be an autograft, allograft. You talked about the different types of grafts. ACL repair, where they're basically, I imagine for a partial thickness tear, where you don't have a complete rupture, you have a tear, that might be more amenable. And you talked about if you're doing bio augmentation or not. Copers, right? A very specific term for, dare I say, the optimal candidate for the non-operative rehab protocol or non-operative management. And then bracing, which is just the strategy for non-surgical management. Is that correct?
Correct.
Okay, awesome. So what do you think it makes sense to go from there? I mean, that's the term, right? So just for the audience, when I think you just randomly texted me asking me if I knew what coper was. And I, of course, read it as copper. And I was like, oh yeah, like the copper sleeve for knees. Yeah, I'm very familiar with that stuff. And I don't know what the evidence behind it is. And then, we of course got on the phone and we talked a little bit about this and definitely collaborated on taking care of somebody. But as I started digging and educating myself, it's well recognized. There are multiple randomized controlled trials, systematic review published as recently as 2 years ago, looking at just non-surgical management in general. And so it's not mainstay, but it's also not something that's on the fringe. So where do you think it makes sense to go next? Should we talk more about how to identify individuals or somewhere else?
No, I think that's a really good starting point on this conversation, because identifying the right individual for a coper, one dictates the rest of what's going to happen with the individual and can kind of lead down into the surgical routes. And I think that's the beauty of that kind of route, in a sense, is that if someone has this potential, worst case scenario is if it doesn't work, get the surgery. It's never like the surgery's off the table. It was once thought, if you don't get the surgery immediately, the, scoring would happen and, the outcomes were going to be worse. And then they actually found out people get surgery too soon, their outcomes were worse. And then they did studies suggesting if we wait and delay it, does that affect their ability to return to sport? And they haven't seen that. So identifying who can be a coper, properly educating them on that, and them how to do things, and then kind of leading them, you have, choices A, B, C, and D now. I think it's the most important thing. And to kind of go over the basic things. So we get a lot of people, freshly, unfortunately, had an ACL tear, and they come into the clinic and we start to examine them. We're looking for things that we discussed, like a quiet knee. But the main things that we're, looking from a research standpoint, and a lot of the research on the copers, if you looked at the studies, it's all from LabVIEW, Delaware, which is not too far from us. Linsider Mackler's group over there has done a lot of the research on trying to identify who potentially is a coper. So they take these individuals, and the main thing I would say, the 4 parameters are, can they do a times 6 meter hop test? So hop testing it's used for all lower extremity athletes, mostly research in ACL population, whether they're done reconstruction or they're going through the coping route. We do a battery of testing to see if you're able and have the ability to return to sports. It's just one of the testings that we do. It starts off with a single leg hop test, a triple hop test where you jump 3 times in a row on one leg as far as you can. There's a crossover where you take a line and you hop from one side to the other side, back to the other side. So we're seeing some frontal plane, a little more lateral component to as well. And then the 6 meter time top test as well is, so basically 6 meters and go as fast as you can jumping on one leg, and we time you. There's also the lateral hop test as well, which is becoming more and more popular. There's a lot of different elements, and it really depends on the athlete. We do neurocognitive style. So, we'll say go on green light or go on red light or something like that. So there's a more mental component as well. So that's more reflective of things that happen in sport. So sometimes some athletes have the strength measurements, they have the hopping measurements, and they look good, but they just don't pass the eye or the kind of the talk test. They don't kind of convey that confidence. And then you start adding some neurocognitive things, and that's when things kind of come through the woodwork, especially for confidence. You'll start to see a drop in 20-30%. So in those hop testing, we'll test the uninvolved side, see, how far they can go. Let's say 10 meters just for simple as math. And then, test out their involved or their surgical side and say, oh, they can jump 9 meters on that. So that's a 90% of what the involved or the surgical side can do compared to the non-involved and the healthy side. So go ahead.
Sherman, let me jump in there real quick. So at what point if point 0 is ACL injury, when are you incorporating these tests in?
So for that, and this is non-surgical. Obviously, you've
already
fresh
determined
off
you're doing that.
This is someone who's coming in. They just had an ACL tear. Usually, it really depends on the athlete or the individual. Well, I would say just the athlete. Some individuals, they come in and you start to look at them and you're like, did you really have an ACL tear? Are you sure about that? We're not seeing anything, which is just amazing about the human body itself. You can have the same injury and see 5 different individuals with it. One person's knee is blown up. The other person looks like they can run a marathon and do a CrossFit competition and play soccer that day. So it really depends on the person. But we want to do this testing when they're safe to do it. So it's when that quiet knee is probably a good idea. They're able to ambulate or walk without any, problems. It's pretty normal. I'm not going to be like, oh, let's hop to day 1 when you came and walk and you're on crutches or something like that. So for some individuals, it's gonna take a couple weeks. I usually say around 2 weeks. Most people, they're probably pretty good. Some individuals, again, we can maybe start on day 2 or something of that nature, where it's, oh, you look good. They feel good. They feel confident. We do some other things of just getting some baseline strength measurements. It's okay. Your quadricep is within 80% of your other. You're probably pretty safe to be able to jump. So let's see where you are with this type of testing. So that's me. I just wouldn't, want to throw someone into it too early and cause a risk of, taking off the joint anymore or potentially, causing any more injuries, especially, again, the ACL does provide stability. You remove it, it's still fresh. But you have swelling in the system, which inhibits the quad a little bit. There's a risk that, they can't hold themselves up and injure themselves more just for the sake of doing a test. So that's my guess. Usually most people within 2 weeks,
have you ever seen an individual who is not unstable, but still has pain?
Yes. Yeah, absolutely. And I think that I see that more often than anything. Most people within the first couple of days, let's say up to day 3, they'll have those little kind of giving away moments and everything like that. So that's a functional sign of instability versus we're talking about, the function of the ACL, the translation. I'd say the main tests that we use as, orthopedic physical therapists or sports physical therapists, primary sports physicians like yourself, is a Lockman's test. Mm-hmm. That's for anybody who's watched like a game of soccer. Guy goes down or gal goes down, grabs their knee. You see them jiggle their knee. That's usually the Lockman's or anterior drawer, which is a similar test. You rarely see that as much. That would be an objective determination of instability. So you'll feel the giveaway, but some people will have that, but functionally they don't show any signs of it. But just because one, pain is multifactorial. You have all the inflammation, you can't cheat that to, it's going to happen. So that's going to drive pain response. And then, just knowing that, trauma happened to the area that influences obviously things upstairs. So you'll have people with pain. But a lot of times they'll be like, yeah, no, my knee doesn't give out. I can basically do whatever I want. It just hurts here and there. Those are the easy ones, to be honest. Like those are like, by the first week, we work on their knee a little bit, get them back into exercises, loading of the tissues. They're usually pretty good within the first week. maybe again 2 weeks at the most, but usually the pain goes away. You may see some things towards end range, like end range flexion, not so much extension where it's a little tight. And maybe that's again, the swelling in the joint or, just overall recovering where it's a little uncomfortable, but otherwise pretty normal. So that's what I see a lot.
Awesome. So you've decided to go down that non-surgical route, right? You've identified that somebody might be a coper. I feel like it's important to throw this disclaimer out there. I know you talked about a variety of hopping tests, but that is not an endorsement for anybody who's recently injured their ACL to go start hopping around and to do lateral hops or timed hops and then, assess whether or not that you are going to be a coper and then walk into your clinician's office and say, hey, I'm a coper. Yeah. These are tests with implications that could be dire, not to scare anybody. And so you want to make sure that you're doing it under the supervision of somebody who is qualified, such as Jeremy, maybe me, hopefully after this episode when I learn a little bit. But that's really, really important. So yeah, I think that's worth stating.
Yeah, definitely. Again, you shouldn't make that decision. It should be presented to you, sort of thing. Wow, you're looking really, really good. Have you ever thought of this sort of situation? And again, conduct it. And I'll be the first one to admit this. I always looking back and self-reflecting on my career. When I was first given those hop testing, many more people passed than they should have. I got the chance to take a course with the people who were part of the research that created like hop testing and FMS and all these other metrics. And I realized how generous I really was at times. Oh, little second bounce, or like you jumped, you landed and you did a little extra. I was like, yeah, you're okay. And reality, that's not proved. And when we're looking at these sort of things, or losing balance after less than 3 seconds. And that's something you'll see. A person can jump, but they don't have any stability versus their uninvolved side. They jump and they stick the landing and it's perfect. Or they're able to jump, but their mechanics on that side, will say is they'll have a hip strategy. So they're not accepting any force through their knees. So they're like, most people have probably heard through the thing like social media, whatever, maybe knees over toes, which got really popular because that's actually an essential kind of movement of human performance or life in general. But post-op or post-ACL injury, people will avoid that. And then they'll use a hip strategy. It won't bend at the knee as much and try and do it through the hip. And yeah, that can get them pretty far, but that type of pattern actually leads to more ACL and knee injuries. So if it's great, you made it as far, but I'm still failing you regardless because you're not doing it the right or the healthy way. If it was, you did both sides and that was the way you did things, that's a different story.
All right. So you talked about, okay, good. Let's get back into it. What about other factors, right? Things such as age, the type of activity level, right? So my understanding from reading some of the literature is certainly high risk sports, right? Getting back to American football, getting back to soccer, maybe even basketball, like you're going to have a different calculation when somebody's maybe returning back to weightlifting, right? Or powerlifting rather. So can you talk a little bit about that in terms of how your decision-making process goes in that conversation that you're having? And maybe that, maybe you're seeing somebody 2 weeks out. What's that like?
Yeah, I think that's something we have to pay respect to. And that goes into why someone should present this option to you versus not. So it's like, not only do we take in the jump test and there's some, testing, qualitative testing, like how you self-perceive things as well. We also want to respect, is the knee giving away? I think that's usually the hallmark sort of thing that we look for. If your knee's giving away, like you're going walking and you start tumbling or you can't control it, that you probably need to have something. You obviously need some stability, so you need a surgery. But taking into account, who's in front of you. Is it a senior trying to wrap up their season and this is their final season? They just want to do it. They look healthy enough. All right, maybe we tried this route and, we're going to do our best that we can. If it takes, great. You finish off your season, then you can decide with whatever you want to do. And maybe you're just like, it feels great still after the season. I'm not going to go for the surgery. Taking into, again, the sport as well. Linsider-Mackler studies There was one looking at copers and versus non-copers, and especially from a return to sport. They classify things as like type 1, type 2 sports. So type 1 is anything like jumping, cutting, pivoting, think soccer, football, basketball, and everything like that. A type 2, which is more, it has lateral movements, but it's like less contact, and it can be argued about that sort of stuff. So there's less of another person influencing on you. Racket sports like tennis, I guess pickleball now, which has become popular, snowboarding and skiing. And then type 3 is I'm a runner sort of situation, and weightlifting. So when they looked at those sort of things and trying to compare who was able to return to sport for those who had a reconstruction versus the copers, ended up being 63% for both parties, which is crazy. Nobody talks about that. Like whether you got the surgery or not, it was relatively same outcomes. I'll say from that study, if you really look at it, there was a little bit more type 1 athletes who got the reconstruction. And I think that's where, we should still kind of push it for those individuals, especially at the elite level. You need everything you can to compete at that level, including stability. And yeah, maybe you can perform. You have these dynamic stabilizers. You get, legs like an ox sort of situation. But you're going up against the best. You're going to be cutting and getting hit at, the most highest level of speeds and forces. That's maybe where we start to kind of, transition someone, especially if it's earlier in their career versus later in their career. I will say this. I wrote a blog about this. It was like all non-ACL team of individuals who performed at the most elite level without ACLs. Heinz Ward, John Elway, Matt Light. Those are just football guys. There's a couple guys over basketball as well. So it's not saying you can't, but it's still, with so much requirement to, be able to stop on a dime, to do all that, you probably want that stability and everything like that. So that's the main thing, is being able to educate individuals about that sort of thing. It's like, okay, based off of where you are in your career, your goals, are you trying to fight for a scholarship, or are you, looking to just again retire? Is this more just a game for you? It's something that's like you're overly passionate about, which I get a ton of athletes are like, oh, I just do it because I'm good at it versus actually enjoy it. Well, are you willing to go through a year-long rehab for something that you don't really enjoy? You're just kind of there for, well, no, not really. Especially that's the one knock on the reconstruction. There is some parts where it's not comfortable. You go from a high level athlete who can do anything, jump up 50 inches, whatever it may be, to not being able to lift up your leg or go to the bathroom by yourself in those earlier stages. So, well, is this worth it to you sort of situation? So kind of seeing where it is. I believe from what I saw was like females actually more towards middle age with no concomitant injuries. So no meniscus tears. And this is just non-operative, non-regenerative. So doing basically nothing at all besides rehab. Those were the individuals that did the best, and still active and everything like that. But those individuals did best with the coping kind of route. So it was just, mid 30s, female. They gave away to, other little things, but that's basically what it is. And I'd say based off of other literature, more or less type 2 sports. Again, I would argue, we see a ton of skiing and snowboarding. I think that's one of the top ACL injuries, and gymnastics is considered a type 2 sport. And that's the highest risk for ACL injury in all sports. So I argue their classification scheme, but you kind of have a gist of idea of, this is where this is sport I'm playing. This is the level I want to play at. Do I want to go through this aggressive rehabilitation for surgery, or do I want to try and see what my body can do? And it's the collaborative process that we have with the patient, and hopefully a good, orthopedist and, sports medicine team to kind of navigate those waters for the patient.
Yeah. Snowboarding, skiing, as fun as it is, it's funny. My brother and I recently having a conversation. He was like, yeah, I really want to go snowboarding. And I told him, man, at this stage in the game, the ROI on enjoyment is not there for me. And you're just not going to get me to do it. You can take my snowboard. Yeah. But we settled and we're going to go snow tubing instead this weekend. So I'm looking forward to that.
I was just about to say, I was like, at this point, I've seen too many of them. I'm like, I'm not that good. It's one thing where I had the, malleability and the plasticity of my brain to pick up on skills a little bit quicker, that sort of stuff, where I'm like, yeah, that window's a little bit past me. I'm like, no tubing. Yeah. With no trees in the near area, I think is pretty safe. But yeah.
The part that was surprising to me was when I was looking at the data on Copers, when they identified these individuals, they had talked about elite athletes in season. And you wouldn't think that, right? It's somebody gets an ACL tear, a rupture rather. You think that's a season-ending injury. That's automatic. Those are the thoughts that go through your mind. Now, of course, there's a lot of nuance to it, as you've already shed light to, but elite athletes, especially that individual who is maybe, redshirted last year in college and they're playing at a high level, playing football, basketball, whatever the sport is, as aggressive it might be, they might be able to rehab, brace, and get back and enjoy. And so at this concept of shared decision-making, I think is very, very important. And yes, at the end of the day, you're responsible for protecting the athlete or protecting the individual from themselves. But that decision-making, like, we have to involve them into it, right? We have to talk about the risks and benefits. And we'll talk a little bit about the risks later on, both of getting surgery and going the non-surgical route. Because again, even going through this non-surgical, there are some risks. And some of the data actually looks at that. Let's shift and talk a little bit about that rehab process. I think, so we've gotten to this stage, right? We've identified maybe the optimal candidate. Actually, before I do that, I want to ask a question. Being in a direct access state where patients sometimes just come see you, if you had an individual who maybe let's not even say they had that pop, right? They come to you 2 weeks ago, young athlete, high level, had an injury in his knee, quote unquote, tweaked his knee, or her knee rather, and comes to you and says, man, I had a swelling for a day. And since then, my pain has slowly subsided, but, I feel like I need to do some rehab or just high level performance and whatnot. What clues give you that this person needs imaging, right? Because on examination and from the story that they've told you, they're stable, right? You can't appreciate any laxity of the ACL. What are some subtle clues you might be able to pick up on that you're like, all right, I really think you need an MRI?
Yeah. So the mechanism of injury is the number one. What were they doing? Was there like a valgus collapse or a hyperextension, or usually my foot got stuck and my body kept going is usually what people report. That's when one of those three things kind of happen, or is reported. That's usually all right, we're going to go through our ligamentous testing. I don't do that for every single, direct access knee patient who comes in, especially if it's pain based versus, trauma based. But if it's trauma based, I'm going to go through my testing. So that's it. Number one, they actually did studies on, taking, hearing the pop, where the patient either felt it or heard it, and took that into our classic testing, which is Lockman's anterior drawer pivot shift, and how much that improves the ability to, I believe it improves specificity, ruling it in that study and everything like that. So that right there, if I hear, someone says pop and that sort of stuff, obviously boom right there. But in this situation where it wasn't reported, and I still are like, kind of, iffy about it and everything like that. The next kind of tier of things is, pushing it. Well, obviously seeing what they can do. If they reported any weirdness, I think that's another one. It's, my leg kind of gave out a little bit or buckled a little bit. That's another little check mark. I got to go through this testing and everything like that. They've done studies on, sports medicine practitioners performing your standard orthopedic tests and everything like that compared to MRIs, and they're equal. The MRI is considered the gold standard and everything like that. So if you have a really skilled clinician and has that kind of gut feeling, has listened, and again, it's mostly mechanism injury, hearing the pop. Some people come in, they walk in, and we call it, I shared Wentworth, who we talked about before, called it the ACL walk. So it's just a slight loss of knee extension, about 20 or so degrees. I can tell it. And she said that. I'll never forget. I can tell an ACL before they come in, just by the walk that they come in on. So those are the big markers, obviously, swelling. the main thing, if it swells, especially like a little bit, it starts to be delayed in the next day, that's a cardinal sign that it's going to probably be an ACL. So, those are usually my things. And my thought process is, always refer out, in those situations, even if it's maybe my testing, especially earlier on. Very early on, I've done a lot of like sports venue coverages. I've just been there, playing basketball myself, and someone tweaks their knees and I'm like, screw it. Sort of situation. Those tests aren't the best, and really like pivot, shift, and anterior drawer. Those are supposed to be designed or are the best psychometrics when the person's under anesthesia. So there you're just going to get protective guarding from the hamstrings and everything like that. So that can kind of cloud things. So a lot of it walks like a duck, talks like a duck. And so you get that kind of feeling, trust your spidey senses, it's refer out. And I've never missed one. And sometimes it's been a case where they said some things, testing may have been a little inconclusive, or one was positive, one was negative, refer out anyways. Just saying an idea where it's, even the mechanism of injury, is enough. It's enough to kind of warrant a refer out. So that's my thought process. I would like to be pleasantly like wrong in those situations, but I always tell people, I hope it's nothing, but you do have a couple of things going against you that may suggest an ACL injury. Let's refer you.
Love it. Give us an insight into what a structured rehab program looks like for a coper.
Yeah. So I'll say this is the beautiful thing about the coper rehabilitation. Again, Insider Mackler and U Delaware did they called it neuromuscular strength training, NMST. They did 5 weeks of 2 sessions a week, which isn't really that much when you think of how long, ACL reconstruction rehab is, which is 9 to 12 months. But the beautiful thing about it, it's basically synonymous with prehab. And that's what I think is the really great thing. We'll get someone like, you can go for surgery, or you can potentially try this route, and the rehabs are similar. Where our first project is get that knee quiet. So we're going to start to work the knee, and maybe we'll do some manual therapy to restore full range of motion, do any swelling mitigation, where we're, tell the people, lift your legs up and that sort of stuff. Not go crazy with it. We're getting people off of ice a little bit more, just because that can potentially delay healing. Same with NSAIDs. So we're trying to guide them through that, get to that quiet knee where it's mostly all your full range of motion. They have good, their quads starting to come back. They're able to make a good quad contraction. Their legs not giving out. And then it's just building up. That's it. It's just getting them stronger. There may be some more single leg or somatosensory exercises where we're challenging them and kind of more perturbations and those type of drills into the mix, and a classic, just generally getting someone stronger. But it's really no difference from prehab to coper strategy. So that's the beauty. You can trial it. Let me go this coper route. If it doesn't work, knees starting to give out here and there, great. All you did was prepare yourself for the surgery. And we know the outcomes are much better with the individuals who go through prehab. But that's the main thing, is we really want, whether it's a person who's going for the surgery or, trying to live life without an ACL, we want to get that person as strong and as robust as possible, get those dynamic stabilizers as the best that they've ever been. So we're hammering the whole system. We don't want to just purely focus on just classic knee muscles of hamstrings and quadriceps and the adductors and your lateral musculature for the abductors. A lot of the injuries, especially for soccer, it's indirect injury. So it's not so much, someone providing contact to you. A lot of it's I hit someone that kind of threw my balance off and then I injured. So we call that indirect non-contact. So that's a core thing. You need to have a good trunk control and stability. So we want to layer those sort of things in, but obviously a heavier focus on getting the knee muscles as strong as we can. So we're doing as early as we can. We're throwing in squats and deadlifts and reverse lunges and single leg hopping and box jumps and RDLs, you name it. There's the sky's the limit. That's where it becomes unique to the patient. but with the emphasis where I'm not going to, yes, you can get a benefit from doing, overhead pressing, but it's probably not the lowest hanging fruit in that situation. Yeah, sure, you can throw it in as part of a good general workout if you want to throw it in, but it's going to be lower body focused.
Yeah. How do you measure progress in that rehab? And I'm curious about if any milestones, right? Is it more temporal in terms of, at 1 month or 2 months is what you expect before you might say, okay, you need to go, you're not improving, you're not quite ready for sport yet. This was our goal, and maybe surgery is the way to go. Or is it more of just, hey, if you continue having instability at some of those higher levels of demands that you challenge them to? You talk a little bit about assessing their readiness for sport, the neurocognitive component of that as well. How do you address that? And then, I'd also be curious. I know we spent a lot of time talking about this aspect of it during our last conversation, so I recommend the listeners go take check that out first. But, treating between the years, as you mentioned, is also very important. And when you've had something traumatic like this, there is a lot of apprehension. I imagine somebody who hasn't had it surgically corrected and is acutely aware that they are either missing their ACL or that's partially torn, they might move differently. What can you say about that?
Okay, I'll start with that, and then we'll circle to the other ones just because that's fresh in my brain. Yes, absolutely. Again, and it goes back to what I was saying before, like people after a procedure or knee injury, they'll develop like a hip strategy, or I call it like a don't trust my knee strategy. I don't want to bend it. I want to load it. I want to avoid that. I want to let the hips or the ankles do it versus the knee. So we'll start to see that. We'll start to see something as simple as a squat shift away from their involved or their ACL injured leg. So we'll see those little, subtle signs, just little things as they move around and everything like that. So that's, those are the basic boxes. Those must be checked before they return to sport. And yes, certainly someone who's torn their ACL, know that it's no longer in there. That could affect that. But I'll say, to play devil's advocate, the same could be said, or even more so, for someone who went through a grueling rehab process post reconstruction, and the fear of, I do not want to re-tear it, also influences people's movements. So I don't want to do this rehab again. Because I'll admit, every once in a while you get some people come out of the surgery, just like I was talking about before, 5 different people. You'll get some people who it doesn't affect them as too much. But most people, there is some parts where you have to kind of grin and bear it, sort of situation where it's not the most comfortable. It's an aggressive surgery. It's not great. The first night 2, night 3 is more like, tell people it's hell on earth. It's the block wears off, your medications, it sucks. And then you have to get the range of motion back after a post-op knee. That takes some time and everything like that. So that process, those earlier stages, that puts a mental scar in people's brain and such, that they don't want to ever have to go through that ever again. So that causes a difference. So that's something that we have to take respect to. And I think, and I hope in my lifetime as a clinician, now that we have these 4 different major routes, that we can start to subgroup individuals. And okay, based off of your mentality or your beliefs, we think you can be someone who can cope without it. Some people are like, I didn't even know much about the ACL. I don't really care about it. I can perform without it. And they've shown it physically, functionally, and cognitively and mentally as well. Or we get someone who's, I'm definitely afraid that, not having anything in there is going to cause worse damage. Well, you should probably get the surgery then, if that's always going to be in the back of your mind. So there is almost a readiness for the surgery. We're starting to see John McMillan put up some stuff from what he's been doing. He does the bare autograft of sorts, the repair. So we're starting to see that sort of thing. I can say that in the prehab phase, there's individuals where I've told them, I'm like, I don't think you're ready for this procedure, just based off their mentality, sort of stuff. And I haven't been wrong with those. So maybe we need to delay it. Or maybe we should hold off for a little bit. But yeah, so in either way, as the physical therapist, that's our responsibility, is to help people work through it. Whether it's a non-op and their belief is, really did need that thing. And most of the time, if that's the case, if that's the belief and we're seeing some lack of confidence as a result of, I don't have a ACL anymore, I'm going to probably say, hey, you should probably get a surgery then. Usually those individuals are highly motivated individuals, or the very opposite. Their career's wrapped up. They're kind of done with things. They're going more towards sedentary lifestyle. They just don't want to deal with the rehab, say.
That last part's interesting to me though, because, when I think about most of the surgeons that I work with, good surgeons, they emphasize that, yeah, the ACL, like I'm going to restore that anatomy back or create something new that's going to function as that anatomical piece that you're missing. But the rehab is what's going to get you back to function. If you don't rehab, you're certainly not going to regain that motion. And if anything, you're going to lose more motion because of the arthrofibrosis that you might get. And you can't just expect it to get better after the surgical part is done. Like that's not the hardest part of it. But, with your last statement is suggesting that there are people who just can afterwards just be like, yeah, I'm going to be functional despite doing a rehab. How often do you see that?
That they'll be functional without doing the rehab?
Yeah, like post-operative.
Surgery?
Yeah, post-surgery.
Oh, yeah, maybe I miscommunicate. I don't see those individuals because they're probably not going to rehab. I'd say that's an incredibly challenging thing to possibly do. I'm not saying it's impossible.
Yeah. I
know some people try and do things online and telehealth and try and kind of go through the motions, but I think it's incredibly, I don't want to say it's impossible, but it'd be incredibly rare to do this by yourself. Okay. I know a guy who he ended up being a PT. He tore his 5 times, 3 on one leg, 2 on the other. Yeah. And he's, to be honest, I didn't really do the rehab for the first 3. I should not do the rehab for the first 3, but he's a kid and that sort of stuff. And it's always that. You do it for a couple weeks, months, whatever it may be, and then you go back to playing basketball, whatever it may be. But just the trauma that goes through the knee after the surgery itself is, I think, too much to be able to restore without anything. I'd love if anybody can prove me wrong and I'm fully back and I do a rehab, but we know from arthrogenic muscle inhibition, like arthrofibrosis or hemarthrosis of the joint post-surgically, you're going to need to restore the range of motion. And if you can do it yourself, and I believe that, I think some people can certainly do, where they're like, I'm just going to generally progress my knee range of motion. But especially the loading of the tissues and everything like that, especially because a lot of people get significant muscle atrophy post-op, it's tough to be able to do it without any help. I'm not saying it's impossible. And I would love if any of your listeners are like, yeah, I did it. And I'm back to everything. I'm like, hell yeah. Kudos to you. Yeah. Sign my goniometry.
You're in the minority there. What about bracing? And I don't mean the cross bracing protocol we had, touched on earlier, but just bracing to provide a little bit of extra stability or maybe some mental support while they are rehabbing. What's the role of that?
So there's the early brace, the early post-op brace, which most of the time it's fixed to, you're locked into extension and then they progressively add more flexion.
Wait, no, I'm actually, sorry. My question for bracing is for copers or the non-surgical management.
Oh, copers.
Yeah,
I haven't seen anything where like that was part of the studies where it's like these are copers with the bracing, copers without. I haven't seen anything actually even mentioning the bracing. I'm sure a couple people have, but these are certain nuances of research where they're not giving you every single detail, especially with even like neuromuscular strength training. It's like, it's a general broad thing. What did they exactly do? We know the foundations, but not exactly details. So I haven't seen anything with bracing. If I can extrapolate things from post-op where you do have a period where you're not as stable because your muscles have atrophied, that ligament, the reconstruction, the graft has to go through ligamentization. So it's technically less stable than obviously a natural uninjured ligament. We take those studies where they have those return to sport bracing. The evidence there is very so-so. To be honest, they give them out a lot, especially in the United States. From what I've seen, individuals, females in the first year of return to sport have to do best with them. After the first year, males, all that sort of stuff, not really any significant difference. And so I want to throw the baby out with the bathwater and say bracing is not good for any individual. I think it's good for the right individual that may say, hey, I'm just not feeling quite confident. What do you recommend? Well, I recommend a brace. If it's someone that's a constant reminder that their knee is wrong or they can't perform or move. They're not the sleekest of braces. They are kind of cumbersome and you have to kind of work around them. They rub up against things. If it's causing you to change how you move, and again, kind of as that constant reminder, then I'll probably say, as long as they are functionally stable and no giving away or anything like that, maybe that's not the best candidate for it. But personally, I haven't seen any research, and I could just be me missing it. And now that you brought it up, I'm like, that would be an interesting thing to look up, and I'll reach out to the group that does all the coping studies. But that would be how I would take that situation. Because again, I know some athletes where it's like, they can't wait to get rid of that thing. And it actually feels like it's a burden versus a help. But some other ones, it's a lifeline. So you have to kind of gauge who's who.
Yeah, I'll have to send you some of the stuff that I came up with. There was actually a trial that I came up called the Canon trial. I forget the exact name of it, but
okay,
in that, yeah. So my understanding it, at least from what I read, they did do some functional bracing with the copers, and that was a really interesting study, right? So I think this one was a randomized control trial where 50% of the patients avoided ACL reconstruction. And, some people might argue, well, that's still 50% who would need a surgery. But interestingly, the people who ended up going the non-surgical route, so the copers that we talked about, had much better outcomes when they had both short-term and long-term. So I think they had followed these individuals all the way up to 11 years. So I think the time markers, if I'm remembering correctly, was maybe 2 years, 5 years, looking at different functional outcomes, pain scores, and the non-surgical approach turned out to be far better. So yeah, I think that part is really interesting. But like you mentioned, I mean, those studies are few and far between, really assessing. I think certainly the prevalence of, I don't know what the prevalence of copers are, I suspect very, very low, given that I had never even heard about this concept. Anybody in my sports medicine circle, and I'm talking specific physicians who I've asked about this, they've said, copper sleeve? No. That's the question they've asked me. And I said, nope, this is what it is. And so, I think that's something that we still need to continue exploring a little bit more in terms of adjunct, either modalities or treatments, and how do you optimize that rehab protocol to get the best outcomes.
Yeah. And then again, there's, even with other things like orthobiologics and everything like that, for the regenerative side of things, there's so many more tools now. And I think we have the main avenues to subgroup individuals into the right, way that works for them, whether it's surgery, non-operative, regenerative, repair. And now we're just getting all these tools and research to kind of augment those pathways even further. And I think that's where it's going to get really exciting and everything like that. I'm a little sad, no matter which route you relatively go, besides non-operative, like straight non-operative, like we're just going to live without an ACL. The return to sport timeline is relatively unchanged. Whether you repair it, reconstruct it, or try to do the regeneration, still, you basically lose a year. 9 months is the hallmark sign, but if you look at a lot of studies, it's more closer to 10 months. But I think, hopefully we keep narrowing things down. Oh, we have a brace at this certain point. We do PRP at this certain point. We'll start to hopefully speed things up. And I think ultimately, obviously that would be a benefit, but obviously, make this a one injury show versus having subsequent re-tears and follow-up injuries. I think that's, these things can certainly help out with that. So
that's surprising to me, man. Like the biologic augmentation piece of it. Are you familiar with literature that's either looked at BMAC and that's bone marrow aspirate concentrated cells, PRP injected into the ACL with with a rehab protocol? It sounds like to me, like if I'm to think about the optimal timing when I might consider doing a procedure like that, might be, certainly when there's no effusion, maybe a month out. I would imagine that individual would return back to sport much faster.
Yeah. I haven't seen it obviously in the reconstruction realm, because they usually don't try to put too much into once it's, it's a graft, you bring things in, God forbid.
No, I'm talking non-surgical. Non-surgical with biologic augmentation.
With what I've seen of, especially like the cross-bracing, the field-based studies and everything like that, they do bring in orthobiologics. And I've always seen from PRP perspective, from what I remember, they were doing it around like day 10, I want to say.
Yeah, we do it early
the
on.
individuals had to be less than a month from the ACL tear to be included into that sort of stuff. And I want to say, and they siphon those individuals off and say, hey, they did much better. They kind of were just looking at, MRIs at 3 months and as the first one to see any actual healing of the ACL. I don't think they subgroup, people who got the PRP, they would say is like a level 1 or grade 1 on that. So that basically the ACL is pretty almost normalized. Grade 0 would be the fully healthy knee ACL with no signaling or anything like that. And grade 3 is fully ruptured. They're looking mostly for grade 1s. I don't think I can't remember in that study if they're like, people who receive PRP were more likely to become a grade 1 because those are the individuals that did the best at 3 months who had a grade 1 shown. I don't think they were able to, but I think just understanding the nature of these type of procedures, PRP, BMAC and all that sort of stuff, where that can only make it better, right? Can only help out the healing process. And I know I don't know how it is. I know the cross bracing protocol in Australia and that sort of stuff, but maybe a little bit different. And over here, it's more challenging to get PRP. So we're maybe not giving people the best chance for this. So I would love to see that, a little bit more dived into the research and everything like that. Cause I think it does give people the best fighting chance if they want to do this sort of thing. It only makes sense that it would help.
So we've teased this enough, this cross-bracing protocol. Talk about what that is. It sounded nonsensical to me the first time you mentioned it to me, but yeah, please educate the listeners on the cross-bracing protocol and the regeneration aspect of that.
Yeah. So understanding how the anatomy works of the ACL, when we're trying to, I guess, have something self-regenerate with anything, just take like a fracture. And what do they do after you have a fracture? They reduce it. They bring the bones as close together, then let the body take the rest of the way. So the same principle works for, trying to have a ligament repair or tendon repair. So they found out, based off of the anatomy that at 90 degrees plus is when the joint approximates the closest for the ACL to bring the two ends closest together, which is a complete opposite of what we do. Typically after ACL injury, we keep people in full extension, right? Loss of extension leads to a lot of issues with the surgery, leads to a lot of issues with quadriceps. So they did the complete opposite and they brace people for 4 weeks to 12 weeks. It goes to 12 weeks where they keep their knee bent to 90 degrees.
Is this the Ihara paper or that you're talking about?
The what? Sorry?
Who's the primary author in this study?
I think it's like Stephanie Philby.
Philby. Okay, the Philby paper. Okay.
The two cross physicians, they're also in it. I can't remember the secondary.
I think that's the one in BJSM, right? Last year, 23 or 20? Yeah, 2 years ago. Yeah,
2023. That was a big one. So it was like 80 candidates, I believe, was in that case series. Oh yeah. So they're braced, they're locked 90 degrees for 4 straight weeks, which is surprising again when you spend, even I've seen it after just a couple of days of leaving the knee bent, especially post-op, where people develop knee flexion contractures, which is a fancy word for your knees stuck being bent, not straight. I think they only reported like either 10% or 10 patients. Obviously that'll change the percentage. I can't remember off the top of my head where they develop a knee flexion contracture, which is, I thought would be a lot more with this protocol, but 4 weeks of, I guess, basically your knees bent to 90 degrees and then progressively taking that away, like straighten out. But it's like at week 12, they completely remove that brace. But for the first 4 weeks, you're sleeping with it, you're showering with it, you're scooting around with it, all that sort of stuff. So that helps out with healing. And I think it was like 72 of the 80 individuals showed signs of ACL regeneration. Of those ones, I think only half of those individuals showed that grade 1, whereas that's that good healing, that significant. I forget what it's the ACL or osteoarthritis scale. Again, where 0 is like a perfectly normal uninjured knee. 1 is that's good. That's it. At 2s and 3s, it shows healing, but it's not good. And fourth is, it's completely ruptured. There's nothing in there. So the individuals, so half of those individuals were grade ones and they did really well. Their outcome scores are all terrific. It's like a 92% return to sport at like 9 or 12 months. The other individuals, the twos and the threes at 3 months. So they looked at the individuals that are grade 1, 2 or 3 at 3 months. The people who are 2 and 3 did not do as well. Like 60th percentile or 60% return, a couple like re-injuries, such and so forth. So not bad though. That's really good. They have to go through a rehab process as well. And obviously 3 months of relatively keeping your knee bent, which is sometimes that would be, if you ask me and I tore my ACL, I'll be like, Jeremy, what route would you go today? I don't know if I would be able to I'd probably find a way, but I don't know if I would be able to keep up with that protocol. I may say, hey, I'm going to go non-operative and just live without an ACL right now. But that's the general gist of their program. Again, the most important part is those first 3 months where they're controlling how much knee extension is allowed. Again, they're showing signs and MRI findings that the ACL can regenerate, and they do implement PRP as part of these studies.
Yeah. Now, I think it's important because it challenges the conventional thinking about ACL norm, right? And where people will tell you there's no way the ACL is going to heal without intervention. And that's clearly not true. So we talked about the Philby paper in 2023, but Ihara, as a primary author, came across at least 2 studies done by his group over the last 2 decades, which had a similar cross-bracing protocol. And they showed that, up to 90% of the ACLs in those protocols have some healing. I'm not saying that's complete healing, but there is some healing. Now, we've also highlighted that we haven't even included other adjuvants that could help enhance the healing potential, which we have available to us today that we didn't 20 years ago, right? So again, for me, this is incredibly exciting. I think it adds a lot of nuance to the conversation of, one, if we go to non-surgical, is that going to have better outcomes or not? And I think hopefully people will leave more empowered as once you make that decision-making process of surgical versus non-surgical, well, actually, if there's a big if there, like Jeremy talked about, if you qualify based on some of those early criteria we had discussed, if somebody presents to you as this is an option, well, then now we can, talk about, what can we add to really give you the best opportunity to return back to sport at a high level and maybe even, without missing a beat. And so that's something that's really exciting about that to me.
Yeah, I think it's great. I think it just gives, I remember the same kind of principle with Achilles tendon repairs. When it first came out, I was like, what do you mean you don't have to have it repaired? Like you can, if you want to call it a heel lift protocol or booting protocol, it just gives, people so many more options. And I remember, I'm obviously the biggest proponent of physical therapy. I firmly believe this is the greatest profession on the planet. Incredibly biased, but it's not the right option for everybody. And I remember having to take that spoonful of medicine when I was shadowing the orthopedist, and I was with him for a couple months. And every time he should have referred to PT and did it, I kept it for a couple months and died on the inside. And then finally I mustered up the courage where I was like, Doc, I'm like, why didn't you refer this person to PT? I'm like literally standing right next to you. And he just said, he's just, you'll see. So the very next patient, he's just, I think physical therapy would be good for you. And the patient literally, and this is Dr. Jeremy, blah, blah, blah. And he is just like, the patient was just like, so do you have any other options? Do I have to do it? Right in front of me, I was like, die. I was like, no. The person's, I'll do anything else. Injection, give me some exercise. I promise I'll do it. The way they say, I was like, there's no way this person's doing that exercise. But nonetheless, and that's okay, understanding that, obviously I think PT is great because it's natural, it empowers you, and most individuals, especially with the great rehab, become more resilient and more capable than they have ever done. But again, sometimes in certain points of life, it's not the best option. So do we have these other options, especially with this aggressive injury of the ACL injury that can be, the right, procedure or technique or whatever you want to call it, or, rehabilitation at the right time for the individual. So I'm super excited about that. And then combine that with all these other adjuncts, as you said, I think it's only going to get better and better and better. So, it always breaks my heart seeing, people go through re-tears or anything like that. I think eventually live in a world where it's, re-tears will be rare, the rehabs will be shorter. And I think it's all these steps going towards it, subgrouping people into the right option.
Yeah, I think patient selection is ever more important, and really for any treatment, whether it's injection, right? Whether it's going to be a more advanced procedure, some of the things that I do, whether it's PRP, whether it's neuromodulation, whether it's rehab, I think that, and again, you talk about your bias, you're not going to find a physician with more strong of a bias towards rehab than myself, right? And so, but that being said, again, it's not for everybody. It is challenging though when patients don't want to be active participants in their care and they're like, just inject me, make me better. Sometimes that's your only option. And sometimes there are other logistical factors that they cannot do the rehab, right? If you're a mom working 2 jobs and taking three kids, you just can't get there. If you can't afford the copays of physical therapy, then that's just not necessarily an option. Doesn't mean that rehab or exercise should not be part of the treatment plan, but maybe formal rehab and something as drastic as missing an ACL is something that probably requires a little bit of assistance and maybe some, external coaching. I know we spent a lot of time today talking about and really just emphasizing the importance of or how we can approach non-surgical management. But I want to be very clear. I mean, it is not without risks, right? I mean, so you just like any intervention has risks, not doing something potentially has risks or costs too. And some of those include potential for knee instability down the road, right? When those active stabilizers or those, tendons and muscles, maybe you have that like an ox, like you mentioned, but over time, those muscles are going to atrophy and you might have more instability down the road, 10 years or 15 years down the road. You talked about the risks of delaying surgery. If you do 3 months and then you end up crossing over to the surgical group anyway, well, that might be time that you've lost, right? That you could have, because now you have to do the post-operative. And yes, I agree with you. I don't maybe necessarily look at it like that, because you did prehab and you optimize your chances of having a quicker recovery. We talked about the higher demand of structural rehab. And then again, the data, as we've already highlighted, is limited. But again, I'd be remiss if I didn't talk about the risks of surgical interventions too, which might be just as bad, right? We talked about the high risk of ACL graft ruptures. We know the risk of contralateral knee injuries are well documented. Postoperative osteoarthritis, that is not something that's insignificant, right? Surgery is trauma to the body. Anytime you introduce structures in there, you introduce instruments in there, you're going to be causing some type of response from the body where that's going to have implications down the road, and you're going to accelerate that arthritic process. And so, and this is not even talking about the immediate, infection and those complications, risk from surgeries, bleeding, that kind of stuff. But, I think it's important for people to understand, well, one, that this is an option and it can be an awesome option for you. But again, to Jeremy's point, you're not the one making that decision. An informed clinician who is an expert should be presenting this option to you. But by the same token, I do think that I would encourage patients to ask, if you had an injury like this, or really any injury, and you are sitting in front of somebody who is suggesting surgical intervention, say, is that my only option? What happens if I don't do surgery? What are the implications? What are the pros and cons between going surgical versus not surgical? And if you can't have that conversation, or somebody's not open to having that conversation, then you might need to find yourself another person to have that conversation with. Do you have any thoughts to add on to that, man?
Yeah, I think that's huge. I think they need to be more autonomous in their decision making, especially versus I'm just going to go, whatever my insurance says or whatever's most convenient. Go. Ideally, especially something like this. Listen, I got a cold and the medicine sort of quick situation. This is a significant injury. I wish it never happened to anyone, but it is just life, especially in athletics. So you should, do your best. Obviously you live in rural Kansas. It's probably a little tougher to access, the most skilled providers, but now that we have telehealth and, there's certainly other options, but to go about finding someone who's, well-versed in this, who's, done the research and everything like that. And then Yeah, that's it. They're a really, I think a really, what makes really great clinicians is they realize, it doesn't have to be just their favorite option to help someone. There's a lot of different options, a lot of different people that can help people, and they should present that to the patients in that sort of sense. So, find these individuals and ask them. And, I think that's one of the best things we can do to help ourselves. And, a provider shouldn't be, oh, no, it's this way or the highway situation. Those individuals are, it's one, it's absolutes. Those are the people you probably want to stay away from. There's certain situations, obviously, where it's high risk and everything like that, where, obviously, if you have a multi-ligamentous injury, you have an ACL, ECL, LCL, that's life threatening. There's a large chance that you've had an injury to your popliteal artery, potentially nerve damage. That's surgery. You have to get it repaired. So, but again, you want to be with experts who are able to guide you through those situations. And as you said, there's pros and cons, the risks to both, surgeries, you can develop contractures, you can develop infections, you can develop, all these other sort of things. Non-operatively, very less stability leaves you at risk for other ligamentous or meniscal injuries or that dislocation, which is the big, scary bad wolf, where it's life-threatening now, versus, this is an orthopedic or arthroscopic procedure. Unfortunately, you're going to get it, sort of situation, but it's probably going to be more enhanced the more times you go into that joint. So presenting people options and taking some time to self-reflect and kind of see where you are is going to kind of guide you into the right decision. And, especially having a great provider who's going to kind of guide you through it. Because it's me, I always tell people, as a business owner, I'm going to make money either way, whatever rehabilitation is. Obviously, I want to do the least invasive thing because I think that's going to be less on your mind. And that may be my own biases. And, less, potential effects down the road, especially from a surgery standpoint. But, we want to help you out and kind of, meet you where you're at and where your mindset is and everything like that. So
love it.
Present all the options and make them.
Awesome. Dude, we've been going at this for a while. Hopefully people are still with us. I know this is important to me. This is important to you. And I think it is something that needs to be talked about more amongst the sports medicine community and just the medical community, the healthcare community in general. So hopefully somebody will feel empowered and informed leaving away from this. If you could give one piece of advice to somebody recovering from an ACL tear, what would it be?
It goes back to surrounding yourself with good people. This is not something that you want to, just, go to anybody. I think one from a moral support system, which helps out healing. We know there's probably studies in every scope of medicine that good support systems, individuals with good support systems do better. So I think that's a paramount thing. And obviously someone who's, well-versed in it. And we always talk about, build your team in ACLs, especially for the athletes. So have your athletic trainer, your physio, your PT, whatever it may be, your sports medicine physician, your sports psychologist, all relatively on the same page. If you can do that, you probably can't lose sort of situation, especially when everyone's working together and they're all invested into you. I think that's the number one thing. And just know it's a journey and a grind, whichever route it is. And that's it. More options. And me personally, I appreciate rehabilitating them all. I see more ACL reconstructions than anything, but on the non-operative route, whatever it may be, it's a grind no matter what. It's going to challenge you, but realize, you stick with it and you have the perseverance to go through it. You're going to come out a stronger physically and mentally. So usually people need a pep talk. So hopefully that's your little pep talk for anyone that's going through it.
I love it. I feel like you've answered this very last question, which is, the theme of our show. My amateur co-host forgot to ask you last time, but we'll bring it up now, man. You've heard this a couple of times. I know you're a listener to the podcast. We're big about putting the health and maybe even the care. And so when you could pick whichever one of those you want, both. What comes to mind for you, or how do you think we can go about continuing to put the health and care back in healthcare?
So main thing is, I basically shed it with everything else. I think with everything going on in, today's world and everything like that with social media, everything like that, there's so much more knowledge out there. It's out there and it's exposed now. Versus again, back in the day, there wasn't stuff on TV and social medias and all that sort of stuff. You just look up in the yellow pages of who to go to and stuff. So, but I think the power is starting to shift back into, back to the customer. I think that's where it needs to be focused on and everything like that. And, we got all this stuff with insurance lately and healthcare and all that sort of stuff. And, I think it's bringing to light of super high deductibles and crazy co-insurances. And, people are starting to realize it's going to cost me money if I have to go through some sort of healthcare situation. I might as well, look out to see who's the best sort of situation. Patients need to reclaim, or people need to reclaim their autonomy in their healthcare decision making and surround themselves with people who want to empower them. I think the best practitioners really don't want you to continue to utilize you. I think as old Chinese medicine was like, individuals would pay their physicians regularly as a monthly rate. And then if they're ill or well, or if they're ill or they're injured and everything like that, they actually stop sending payments. So I incentivized the practitioner to go, well, I'm not getting my money from XYZ. I'm going to go help this individual. So it shifted into obviously a privatized system over here, but I think patients need to kind of, do their due diligence, kind of surround themselves with the best people, and ultimately work on yourself. I think everybody's entitled and should be able to work on themselves from a physical and mental standpoint, and that itself will limit any need for any health care of sorts. But I think if you surround yourself with great people personally and healthcare professionally, you're gonna do great. It just may take a little research to get to there.
Dude, I love it. I love doing this with you. I'm glad that we got to sit down behind the mic and do a couple of this, although I know we're going to do a lot more of these off the mic too. So thank you for being here, man. Thanks for all the work that you do. I think the world of you guys are amazing, and the team that you put together is just absolutely incredible. So thanks for being here, man.
Of course. Thanks for having me, and appreciate it. Thank you for bringing this out and starting to inform people and helping people bring the health back in healthcare.